We change gear a little bit, topic again, so it's all about swallowing, so dysphagia and neuromuscular disorders, and it's my very, very great pleasure to have Tiziana Mogini with us. She's from Turin. They are running the Neuromuscular Center since many, many years, and she has a lot of experience in swallowing and neuromuscular disorders.
Okay. Thank you, Benedict, for the invite to the presentation. Hello to everybody. It's always a pleasure. And it also a good thing to talk about swallowing weakness after the coffee break, so you can be sure that everything was working correctly. So swallowing is my disclosure known for this presentation. It's an important function in our life, like breathing. It's so easy. We do it many, many times without thinking about it. But it has an influence of at least three main points in our life. That is surviving, of course, for the nutrition, but also for having pleasure. Because for some people, the eating, the tasting may be close to an art. And not the last, to improve the socialization, because so many things have been discussed, and probably you have discussed around the table with people talking and eating and enjoying. So the problem in swallowing may be very impacting on the quality of life of patient. And we have to remember to check in all our patients, since it is a very common presentation also, we have to be well aware, like the breathing, like Stefan said. So swallowing is a complex mechanism that requires the integrity of the anatomical part of the neck, but also central nervous system and peripheral nervous system pathways. So if something is wrong in all this system, the simple swallowing gets impaired. The technical definition of swallowing weakness, is dysphagia, comes from the Greek word that means abnormal eating, and technically is defined as the difficult transport of the food from the mouth through the esophagus without post-swallow residue. And it is a common complication of many, many disorders, not only neurological, but it is maybe a life-threatening event, so deserves a lot of attention. We can distinguish three phases. The first phase is the oral phase, when the food is prepared to get into the stomach, and here it requires the function of the masticatory muscles and mimic muscles, the tongue, the coordination of all these movements. And this is a very important phase. Then the bolus is pushed behind, and here the pharyngeal phase. You have to remember that in this phase, it is under the voluntary control, but also with involuntary muscle actions that needs to be coordinated to close the upper airways, and to close, the glottis closes the trachea, and the bolus can progress correctly into the esophagus. And then the third phase, that it is also important to evaluate swallowing problem, because in this phase, the important role is the smooth muscle that also can be impaired in our patient. And so if there is a block in peristalsis, the food stays upper and can, of course, create an inhalation. So the general causes of dysphagia, there are several. We have aging, we have sarcopenia that our colleagues who works in geriatry are so frequently treating, observing, but also, of course, in all neurological disorders such as movement disorders, cognitive disorders, multiple sclerosis, stroke, whatever is limiting the central nervous system pathways. But before going to diagnose the cause, it is always a good idea to to exclude the structural causes, because they may be common also in patients with a neurological or neuromuscular disorders. I remember a case with severe dysphagia that we couldn't explain in a limb-girdle muscular dystrophy, where it is not so common, and he had a very big osteophyte in the cervical spine that could close push the pharynx, and that was a potentially treatable cause. And also thyroid, always look to thyroid dimensions, or of course to lymph nodes or other cancer that can be can create an obstacle to the progression. So this is the background, but when we talk about neuromuscular disorders, of course, this is very common, because both in oropharyngeal and esophageal dysphagia, we can have a specific syndrome. Most of the neuromuscular disorders that we have talked today have an oral and oropharyngeal disorders, such as the common neuromuscular disorder. We will see more detailed, but also the esophageal smooth muscles are important, and we see this more in some subtypes, but in inflammatory myopathies. They are emerging with the overlap syndrome, with rheumatological muscle myositis, but also in necrotizing myopathy, in some dermatomyositis. This is really an important feature. So this is a long list. I don't like to present a long list because it looks like the index of a textbook, and it is impossible to read all of this. This is a very good table in the paper that Zohar Argoff and Marianne de Visser published a few years ago. It is absolutely complete, but what I try to do is to separate what is more common to be observed in pediatric age and in adult age, and I try to make a sort of priority list. I couldn't find so many epidemiological data about the incidence in each of these diseases. So I tried anyway to make a sort of classification in order of the most common. And in pediatric age, of course, SMA1 is one of these. Mitochondriopathies, infantile mitochondriopathies, congenital myopathies and dystrophies, and also congenital myasthenia. They are almost always present in this patient. In adult age, we have to think to treatable causes, of course, first of all, and myasthenia gravis is one of these. Myasthenia gravis usually has an onset with extraocular muscles, but dysphagia may precede or be together with the general fatigue. I think that after me, somebody will talk about the fatigue. The fatigue is also the fatigue for dysphagia. Most neurological disorders like neurogenic disorders like Guillain-Barré, some neuropathy, polyneuropathy, acquired polyneuropathy, Kennedy disease, and LAS, of course, you have to take in mind. Then we have oculopharyngeal muscular dystrophy, very rare in comparison to the other one. Most common, myotonic dystrophy type 1. I think that in myotonic dystrophy type 1, you should always evaluate the bulbar function and swallowing function, because very often they don't report any problem, but they have, and they tend to deny the problem, but you have to evidence if they are present, of course. The mitochondriopathies, the 30% of mitochondriopathies have swallowing disorders, as I told, the inclusion body myositis, of course, but also necrotizing myopathy, dermatomyositis. One thing that is not probably so evaluated is a late stage of Duchenne muscular dystrophy. Now we have very old Duchenne patient. In my place, we have a 50-year-old real Duchenne patient, and after 35, 38-year-old, all of them have swallowing problems. And this is a problem for them. It's a problem to to let them accept to change their habits to their nutritional habits. And for them, one of them said, I cannot eat anymore, it is worse than when I lost ambulation, because this is so important for me to appreciate the food. I want to eat the food. And if it is dangerous, it doesn't matter. So this is probably another problem that is emerging, because we didn't have so old Duchenne before. Fortunately, now we have. And also in facioscapulohumeral, we have most problems that in the masticatory phase for the mimic muscles, less for the bulbar muscles, for pharyngeal muscles, but for the preparatory muscles. So they have different kind of dysphagia. So some issues, some cues. What does the patient report? And then you can think about a swallowing problem. When there is a cough during feeding, with the double food consistency, when they say they need repeated swallows, long-lasting meals. I remember a wife of a myotonic dystrophy that said that you are slow, you're terribly slow when you eat, but this is because he had, of course, initial dysphagia. Nasal regurgitation with liquids, the wet tone of voice and a nasal voice. When he talks, you can feel that there is a nasal tone of voice. And of course, fatigability, general fatigability, and recurrent aspiration of pneumonia, ab-ingested pneumonia events. When the patient, on the contrary, reports more retrosternal pain, throat pain, or he says that he feels the food stuck in the throat, that could be more probably an esophageal problem. So you have to think more something that limits the progression of the food. But of course, you need to examine this patient. So if you are suspecting this, you have to characterize this defect, the symptoms, the temporal development. It is acute, it's chronic, recurrent, where he feels the problem subjectively. If it is related to certain foods or certain condition, there are also some psychogenic dysphagia. They are described in the literature. It's not so common, but could be also a problem, a psychological problem. You have always to evaluate. This is for all our patients, but for this scopus, this nutritional status, ask about weight loss, and of course BMI. And then remember to ask about medication, because neuroleptics may also worsen the dysphagia, and also which is the current diet. So always ascertain the neuromuscular disease if it has not been done, because maybe this is the first time that you see the patient, so you have to go over on the diagnosis. But more often you have patients with already diagnosed disease, ascertain that is a correct diagnosis, evaluate the tone of voice. Usually I make the patient cough. And you can hear the sound of coughing that is weak, and it is a different sound when it is closing the pharyngeal muscle with strength. There are many tests that are the water swallow screening test. You can do it in your office. You don't need other consultant, and so there are some standardized, but every place I think have his own procedure that they used to do. That is 4 drops, 1 little spoon of water, and then talk and to hear the voice. You can realize that some water is staying on the larynx. The slurp test, it was designed for my asthmatic patient. It is sucking some liquid with a straw and making it repeatedly. Then you can test the strength of the muscles. So of course, it is a global evaluation. Then, if you have the doubt, you have to confirm, you need the instrumental evaluation. The gold standard are 2 to examination that are done by specialists, that especially that care about swallowing, and that is the endoscopic evaluation. This is very easy. Can be performed at bedside, but it's not easy to be performed in some patients with respiratory insufficiency. It evaluates the motility. They usually, it is inserted on the nasal way, and they give some stained food. They can check the permanence of some foods according to the consistency. Then they may give indication to perform the videoscopic swallowing study, which requires a X-ray apparatus, of course. I show you some of the patient. This is a late onset Pompe patient, which has some very few symptoms. You see, there is just a very few stagnation of food here. But what happens, I hope it's seen, yeah, this is a Duchenne muscular dystrophy, 34-year-old. It is just the beginning of the weakness. You can see the stagnation here, but here there is something that appears, comes again, okay, here, that goes over the epiglottis. And this is an SMA patient, a 20-year-old SMA2 patient, which has very dangerous situation because the contrasted food is definitely staying on the epiglottis, and it is getting into the trachea. So this is a limit for the nutritional by mouth. So also for the children, some techniques have been developed that is not easy for infants, but this is very important to have the tools that approve, they evaluate, graduate the problem. There are a lot of questionnaires. They're old questionnaires that have been studied by gastroenterologists and by specialists, but they are not dedicated specifically to our disorders. What we have since some years, specific scales for neuromuscular disorder, I don't know, they are not so widely used. For LAS, we have very precise scales. Questionnaires, not scales, sorry. And this is one of the last one that are being created, a questionnaire for the clinical study, because one new problem about evaluating this dysphagia is that it is an important issue for evaluating the efficacy of a drug. We've seen in spinal muscular atrophy, in advanced stage patient, do not report improvement in motility, of course, because they are in an advanced stage, but they report an improvement in swallowing. So we need something that proves. So there is really a big effort to create new scales to evaluate this, to demonstrate statistically that there is an improvement, not just the report. So all the recommendation says that we have to check the swallowing function in our patient. Just a few words, if I am on time, yeah, may I go? About SMA. Dysphagia in SMA has many different levels. We talking about SMA1, of course, the most severest form, but that are not all of them are treated, and not all of them are gaining the normal development. We still need observe a craniofacial abnormal morphology, malocclusion, reduced lip strength, reduced tongue strength, and the weakness in pharyngeal muscle. So the more components that are not working together, they are not so easy to define which is prominent and to evaluate with the scale. So there has been a big effort from all the groups working in clinical trials, and still are coming new validated tools. One of these is the Iowa Oral Performance Instrument that measure the lip and the tongue strength, and also the opening of the oromandibular articulation, and the test of masticating and swallowing solid ingesta, the Thomas. Thomas has also been used in mitochondrial patients. So you are interested, you have to go through all these references. There are much more are coming. The same for myotonic dystrophy type 1. Many trials are ongoing, and the Iowa instrument has been accepted as an outcome measure. So the demonstration of the improvement with the standardized instrument may judge a treatment with efficacy. So this is very important to have this instrument. The same for mitochondria, but for mitochondriopathies, many trials are also ongoing, and for several other disorders. Just 2 words about oculopharyngeal muscular dystrophy that have a more complex, again, the different situation, because dysphagia usually appears later in life, after the eyelid ptosis, and maybe not properly identified, not timely identified. Usually it includes solid foods and then with liquids, differently from myasthenia, for example, that have liquids appearing first. And there is, of course, a slow decline in BMI because the patient is slow and it doesn't need enough because he has this unreported problem. It has been demonstrated. I can show you this. This is one of our patients, just initial reporting the problem. You can see there is a sort of closure, and what is different from the other disorders is the contraction of the upper esophageal sphincter. It is typical. It was considered one hallmark of this condition, and it has been also tentatively treated and addressed for a therapy. So there are, of course, here also some new therapies that are emerging, and I invite you to read this paper about the dysphagia method. It is a patient-reported outcomes done very carefully. It has been validated. On a large number of patients in Canada. You know that oculopharyngeal is much more prevalent in the Quebec area. And so there are this is a grade to evaluate the swallowing with the radiological system, and this is dysphagia method. That is very interesting because there are all the reported measures from the patient, you know, that they are describing what they consider better or not. This is a patient-reported outcome. In the sporadic inclusion body myositis, the same. There is a very recent publication that describes very carefully what has been observed in up to 80% of patients develop dysphagia, maybe not so severe, but they have. And also there is the inclusion of more muscles that have been demonstrated histological. They have an infiltration, inflammatory infiltration. So this is a very recent publication, maybe can be further studied, of course, because it is also an important point with the slightly different muscle involvement. These are 2 publications about, you can see also the hypertonic upper esophageal sphincter. So opening some more treating options, of course. So general tips to the treatment of dysphagia, they are quite common old, you probably know, to modify texture, the temperature, and the consistency. You can use thickening agents, monitor the body weight and also the BMI, and check for initial sign of malnutrition, and check also with the hematological test, of course. The maneuver that is suggested by logopedic people, that is to take the head folded forward, to touch the sternum, and so facilitating the progression of the bolus into esophagus, partially closing the tracheal, the airway input. So this is always suggested, seldom they do, and also the physiotherapy is very important. We saw many changes, very useful support from a correct exercise, also in swallowing, and there are experts in this. We have a very good physiotherapist for this that really help some patients. They can avoid some more invasive procedures. Of course, the hypertonic upper esophageal sphincter may be treated with botulinum toxin. That is the first treatment. When this is not enough, when the risk of inhalation is too high, of course, you have to think of the parenteral feeding for the moment, of nasogastric tube feeding that it has a very limited time, not more than 15 days. You cannot leave a patient with this for a long time. But then the gastrostomy, with both techniques, when you have the people able to do it, they are radiologists usually, but you have to consider the ethical issues. In this case, you have to evaluate, to talk with the patient, talk with the family, and also explaining what is next after this procedure. So do we need more specific protocols? This was the paper published in the 200 in 2022. They concluded that there is a need of shared protocols to treat, but of course each center has its own protocol. Maybe it could be a good idea to have a shared protocol, but you have to consider so many diseases, so it's not an easy task. But in the evolving therapeutic area, it is probably necessary to have outcome measures for this. And this should be an effort for the community to produce, validate, and it is ongoing, of course, not for all the disease. So in conclusion, the dysphagia is a very invalidating feature in several neuromuscular disorders, maybe life-threatening if not correctly evaluated. When you collect the medical history, always ask about swallowing, nutrition, specific issues, because they don't report it. Probably they forget, because if they are initial, they may not report this. In all the visit, you have to ask about this, and in the case, make some easy test, as in the outpatient office. Questionnaires, of course, endoscopy and video fluorography are the complementary method, the gold standard to evaluate the dysphagia. And disease-specific outcome measures are ongoing, and probably we should use more in our evaluation of the patient. But this is another problem. Time is another problem. Okay, so I thank you for the attention, and I finish.
Perhaps there might be a question.
Okay. Still awake enough to make questions?
Still awake enough.
Still awake
any
enough.
questions around swallowing, dysphagia? In the back, please.
Oh, thank you. Hi, thank you for highlighting this very important subject. I have a question. I saw that you are advising thickening liquids in patients with neuromuscular disorders. We advise thickening liquids in patients with central neurological disorders, when the problem is in the coordination of the swallowing movement. But actually in neuromuscular disorders, we do not advise thickening liquids because of the increasing risk of pharyngeal residue. What is your opinion on that issue in
Okay,
neuromuscular
I think
disorders?
that it's very important, the evaluation, because they are so different in neuromuscular disorders. You don't have a unique performance, a unique kind of impairment. So the generalization not to prescribe the thickening to all neuromuscular patients is not correct. Usually, I'm a neurologist, so I rely on the colleagues that work on this, we discuss. But in some cases, if the fluorography or the characteristic of the weakness allow this, you can do it, why not? You have to rely on the results of the procedure, the exam of the single patient. Do not generalize, because different phase of the same disease, different disease may have different approaches. So evaluate it with the specialist that is in your place.
Okay, so we have online questions, so we should go for this, of course. Is there a correlation between the consistency of food, whether it's liquid or solid, and the underlying pathophysiology?
Well,
very easy question.
Very easy question. Let me study a little bit.
Yes.
No, well, again, you cannot generalize. You have to evaluate your patient. Of course, thickening the consistencies is one of the solutions. But if the patient has difficulty in the dysphagia matter, it is very well demonstrated the priority of this patient. And for example, they think that cold sparkling water is easy. And they report this, the hot coffee is easy. So you have really to ask to the single patient what is more important, then you can treat them. It is a tailored therapy approach. Then the theory maybe can explain the kind of movement. As I showed you, there are different patterns of involvement, really different patterns.
Thank you.
Thank you.
So one of the big challenges for swallowing for Bavarian patients is the combination of beer and Brezel. So because that is really very bad. So most of them do, if you ask for this, then you have some. Is there one more question? One more question. Okay.
Yes, hello. I'm a speech language therapist. Thank you for your talk. And in our center, we use oral facial muscle ultrasound to detect what problems are underlying the swallowing and chewing problems. Do you also use it, or do you have other ways to detect what's the underlying mechanism?
Okay, no, we also use these systems that are quite shared among. Again, we have this speech specialist about this. We collaborate a lot, and we have a very good one that solved some problems. So this is a good way to collaborate, of course, a very important one.
Thank you.
Thank you. So again, we've heard this today several times. Team approach is the most important for the care of our patient.